posture. It's one of, get that right, important places to go in the living room. One of the things that you guys have to do for kines class is assess posture. And it's actually going to be one of the jobs you're going to have in the clinic as well. So when you're assessing posture, you need to know those bony landmarks we talked about last class. So I'm going to bring up a posture assessment look at here real quick. Let me get that brought up. And share screen. All right. So when you're looking at a patient's posture, what you really need to be able to do is find those bony landmarks and then document where things deviate, right? So can everyone see the guy standing there with all the lines drawn on the person? Okay, good. So when you're looking at a patient, we are going to assess posture from an anterior view, from a left lateral, from a right lateral, and a posterior view. Not only do we need to assess where that median line falls on the patient, but we also need to assess how their overall lateral views kind of look, right? So when we look at this patient over here, so when we're looking at this anterior view on the patient, let me move this out of the way here real quick. We're going to have this standard plumb line that's going to come down through the patient here. When you're looking at the anterior view, the plumb line should pass down through the midline of the nose, down through kind of the center line of the sternum, coming right through between those two sternal notches on either side of the sternum, eventually pass through the xiphoid process at the distal end of the sternum, pass through the umbilicus here, fancy term for belly button, should pass midway through the pelvis and bisect the pelvis right at that pubis symphysis. That midline should fall between the knees and eventually end up landing between the toes at the base. Now this guy's standing a little close with his feet. Normally feet are about shoulder width apart, but this, I think they did this picture so that it helps demonstrate how that line should fall between those knees and the feet. So we're going to assess, when we're talking and doing that anterior assessment of posture, we're going to look at and go, okay, where does that midline fall when it comes to the nose? I need a smaller line. There we go. Where does it fall when it comes to the umbilicus? You know, where does it fall when it comes to the lower end of the pelvis? Now this can be awkward because we don't exactly want to go and palpate the lower end of the pelvis, but we're going to go based upon view. It's not like we're going to say to the patient, hold on, let me palpate your pubis symphysis to see if the plumb line falls where it needs to fall. That would just be awkward. But we have a good view of it when we're assessing posture. But when we have an assessment of posture, one of the things we're going to have to do, ideally, the best way to assess a patient's posture is if they have no clothes on whatsoever. Because clothes can throw off our views. Now, talk about awkward. That's pretty awkward, right? So usually what we're going to ask the patient to wear is something like bike shorts. And if you have a female patient, usually wear a sports bra or some sort of a tight, upper top that allows us to have clear view of the body landmarks. Normally what I would do in this case with you guys to do the postural assessment is I'd set up an area up front. You would all come up front to me to the body grid, which we'll talk about in a bit. And I would take pictures of you in all four poses, from the anterior view, lateral view, and posterior view. And your job would be to take those photos home and assess your own posture. It's a little hard to do now with COVID, right? So we're going to have to kind of talk through this postural assessment so that you guys can clearly understand how this works. So the first thing you're going to look at with the patient is kind of that vertical plumb line. Once you've assessed that vertical plumb line, now we need to start coming through and looking at horizontal aspects in the front. So we're going to look at things like, I'm going to clear my drawings off here and change colors. Let's change to maroon. We're going to look like, are both tops of the ears level and are both earlobes level, right? We can even look, especially if we're looking at a stroke patient, are either sides of the mouth even? We're going to come down here and look at their acromion tips, or their acromion tips level. And then we're coming down here. What do you think we're assessing down here? ASISs, right. And then we can come back here, right, and assess, are their greater trochs even? And then we start at the top of the patella. Are the top of the patellas even? Are the bottoms of the patellas even? And then how about their malleoli? Do they fairly well match up? And the PSIS as well. Yeah, PSIS we're going to worry about more from the posterior aspect in a bit here. Now, the only way we can do this is by getting hands-on with the patient, because just looking at them, we may miss things. Now, if you have a good postural analysis grid chart, you can see it really clearly. I'm going to bring up a picture of that in a little bit. But just getting your hands on the patient, coming down, does everything match up, right? Find their acromion tips. Does everything look normal? So initially, what you're going to do is assess them at baseline posture. So you're going to have them go stand by the postural assessment grid, and you're going to tell them to relax, and you want them to stand in their normal posture. One of the other things we're going to look at is their hands, right? Not only are the fingertips even, but what do they look like when they're resting at their sides? Are they fully internally rotated? Are they fully externally rotated? Are they about mid? Ideally, you want them kind of in that mid position would be perfect for this case. But a lot of times it's not. A lot of times you're going to see is a lot of patients are really heavily internally rotated just because of this posture here again, right? And they get stuck in here. You need to get on to those ASISs. You need to get really good at finding ASISs. Now, for me, I'm going to tell you from a standpoint, I'm okay with you using your thumbs to find ASISs. As long as you're not pokey, right? I don't want you going, oh, let me find that ASIS I'm digging. Okay, oh, there it is, right? Dr. Ovreskin really does not like pokey fingers. I'm going to warn you in advance. Dr. Ovreskin prefers when you palpate with a larger flat surface. Just through experience, I find that finding with pokey fingers, I usually find better, especially if you've got a bigger patient. But understand that this is just like in a real clinic. You're going to have certain clinicians that prefer it one way versus certain clinicians that prefer another way. So when you're in her classes, specifically next semester, make sure when you're palpating bony landmarks, you have big, broad, flat surfaces. Now, that also helps when you're palpating areas that can be awkward. Yeah, palpation journal, exactly. Well, I'm just warning you. I try to get you guys kind of prepared because I've worked with most of the clinicians now as a whole, so I understand kind of what they want. You know, especially, you know, when we get into the point where we're palpating maybe up in the chest to find pecs and stuff like that. It did, that's fantastic. Flat surfaces clearly delineate you're not doing anything untowards the patient. When you're palpating down around the pelvis, nice big flat surfaces kind of let them know, you know, you're not palpating things you shouldn't be palpating for. Even in the case where we might actually have to palpate the pubis symphysis, I will admit at that point, yes, I will use a broad flat surface of my hand. I'm not going to palpate the pubis symphysis like this. That would just be awkward, right? So I just want to let you know that that's kind of when you start to get to know your clinicians, how you want them to do things, right? For the patella, I'm okay with you kind of palpating around and kind of, I use, and when we get back to class, I'm going to show you the method I use for finding the superior and inferior aspects of the patella. I kind of use a circle method where I sweep up from the sides to find it. Dr. Ovreskin and Dr. O'Neill both use the kind of sweep method where you drag 2 fingers down until you find the patella surface. Either of those is valid. It just depends upon the way you were trained, right? But again, that broader surface is a little less pokey for patients that might be smaller. It also is a little better if you have somebody that's ticklish, right? I don't know if you guys found that out, but you know, certain people are ticklish. And when you're palpating them, it makes the ticklish worse. So when you have big, flat, broad surfaces, it kind of calms down that response of that giggle and shiver away from you. So that's looking at from the front view. We're going to switch from the front view and go look at the posterior view, then we'll look at the side views here. So when you're looking at it from the posterior view, again, the first thing we're going to do is go right down that midline, right? I'm really good at drawing a straight line. So the midline is first of all going to go down the back side of the head and fall through that major occipital protuberance, right? That major pointy part on the back of their head. Now, not everyone's pointy surface in the back of their head is even. Sometimes it's a little lumpy, or sometimes it's to the right and sometimes it's to the left. You have to be careful with that. But it should go through generally the midline of the back of their head. As it passes down through, it should pass through all the spinous processes of the posterior aspect of the spine, right? The spinous processes are things you can actually palpate by running your finger down the midline of the spine. It'll eventually come down here where it passes evenly through the PSISs, or the dimples on your low back. It should fall evenly between the gluteal fold. So it should fall right down through the butt cheeks, right? Pass down evenly through the knees, and again, end up where it comes out kind of evenly back between the calcaneus. Now, I often hear a patient or hear clinicians go, well, do I have to palpate their butt to see if it's passing evenly through their butt cheeks? Not necessarily. You can usually see that pretty clearly, and especially if they're wearing tighter clothing, it's really easy to see. If not, you may have to get a little hands-on and kind of feel and make sure that it is passing evenly through. Once we've kind of done that vertical assessment, the next thing we're going to work on is the lateral assessment, right? So what do you think this line's representing here? That kind of horizontal line up top there. What's that going across? Going across scapula. What part of the scapula? Yeah, the scapular spine. Good, right? Exactly. So we're looking at, are the scapular spines even, right? And again, the patient has to be relaxed for this. If they're all tight, now the scapular spines are kind of pointing upwards. You might get an uneven result, right? So you want to have them nice and relaxed. Then we're going to come down here and we'll look at another part of the scapula. What are we looking at down here? You know this is going to be an anatomy lesson. Right, the inferior angles, right? Not the inferior angels. I'm going to palpate for your inferior angels. Sorry, Dylan. That was a good one. I mean, technically, you're not wrong. That is the inferior wing. So, I mean, I guess that technically is the inferior angels, right? And then we're going to come down here and we're going to find those dimples and make sure it kind of goes right through those PSISs, right? And again, palpating and kind of find those PSISs and making sure they're on it. We go a little bit lower, and now we're kind of in that bottom part of the hips, and we're coming down to where we get to that, just about to that greater trochanter. Then we look, are both their inferior gluteal folds even? Now this can come into play because some people's gluteal folds are there and some people's gluteal folds are down here. Well, maybe we'll have to move down and get the gluteal folds down here. You're just looking to see where those gluteal folds fall. And then coming here, does it fall through? What are we looking at here? What's this line? What's that line on the back of the knee? I'm glad I made some people laugh. What do you think we're looking at there? The knee armpit. Good, right? What is the knee armpit called? The popliteal folds, right? And a lot of times what you're really looking at when you're looking at down here is you're looking, is it falling kind of right across those tibial plateaus? Right? And then coming down here, are their calcaneuses even? And then also, you know, looking at this, how do their feet land? Just like their arms. What do their feet look like? Are they toed out? Are they toed in? How does the overall foot look? So now we've got the patient's normal assessments from the front and from the back. Well, the next thing we're going to look at are the sides. So again, we're going to follow this vertical plumb line. That plumb line should fall down through the middle of the ear through the EAM, or external auditory meatus, also known as their ear hole. right? Where does it fall when it comes down here to the shoulder? What are we looking for? You remember from last week's lecture? Good. At the acromion, good. When it comes down through, does it kind of go through the midline of the humerus? Doesn't have to be perfect, but does it kind of bisect that humerus evenly? Then we're going to come down and we look at, does it come down through one of those styloid processes? Does the line fall posterior down here to the knee? Right? Does it end up going through the lateral malleolus, right? Just anterior to the lateral malleolus. The vertebral bodies are going to be different depending upon whether we're looking at cervical, thoracic, lumbar, or sacral. Depending upon where they're at, will depend upon what part of the lumbar bodies or through the spinal bodies are passing through, right? Whether they're passing directly through the body, anterior, posterior to the bodies. But then once we've got kind of that vertical view, then we got to start looking at kind of a horizontal view. Here we're looking, is the pelvis level? So if I put my hand on the ASIS and I put my hand on the PSIS, do they level off? And is the pelvis kind of level? If it isn't, we document what's different. I also like to look at, when I look at this patient, this level here, the styloid process should fall at about the greater trochanter. Let's know. I missed a no somewhere. Okay. And this is going to come into play when we measure assistive devices, because one of the things we're going to measure with assistive devices is the height of that assistive device. And most of the times we're going to use either the greater trochanter or the radial styloid process, because they should be at about the same level on every patient. Now, unfortunately, it doesn't always happen. Like, I'm going to take myself, for example. I have T-Rex arms, right? I have little arms. My arms don't go all the way down when I stand up, that they don't stop right at my greater trochanter. They're actually above it. So for me, when we measure assistive devices, I have to adjust my assistive devices accordingly to me, right? But on most patients, those styloids should fall just about at the greater troch, right? We're going to look down here also. What does their arch look like, right? For most patients, they should have a nice pronounced arch. And we can usually see it a little bit better from the anterior side, but we can still look at it from the lateral side as well. Is the foot completely flat on the ground? Does it have a nice arch? Does it have a high arch? What does their overall posture look like when they're in standing? So now what we're going to do, and it's really helpful if you take a patient photo of this, which is what I would have done with you guys, like I said, if we're in classes, you would have each had to assess your own posture. And that usually is about the time you start realizing how bad your posture truly is. I like to joke that this semester is a semester that we actually completely and utterly body shame you guys, unfortunately, because we do these postural assessments. And then on top of that, we're going to do anthropometric measurements where we measure your height, weight, girth measurements, and then also your BMI. And then we'll go and we'll measure flexibility. So this whole semester is about completely destroying your overall body image. Just saying. But that's kind of how we're going to look at the overall assessment. And what we would say then is if we're looking at that anterior assessment and we notice that maybe this left earlobe is here and the right earlobe is here, we're going to indicate that the left earlobe is lower than the right earlobe, or the right earlobe is higher than the left earlobe. Either of those mean the same thing. Yeah, it's not fun. Trust me, Justin. I participate in it too, and then I cry. I go home and sit in the shower and cry a little bit. We're going to look at those, again, those areas, we're looking at those acromions. Are they even or are they off kilter? We don't want to correct any posture until we know what their normal posture looks like. Because once we have these, it's really beneficial if you take pictures of your patient to sit down and assess their posture with them. And that's why I give you guys photos of yourselves, because most people think, well, my posture is not that bad until you see it. And then when you see it, you're like, oh my God, my posture is horrible. Because you don't realize quite how bad your posture is until you've seen it. Let me change photos here real quick and bring up the line of bod. So share screen, line of bod. So this is typically what you're going to see when you're in the clinic as far as assessing posture. These postural analysis charts, or the one we have is called the Alinabod. The Alinabod is just one of those brands that makes the postural analysis, right? So you're going to have one of those plumb lines, and you can see clearly here with this one, they've got this nice red plumb line going down through the middle. That's tied to a nice weight down here at the end that keeps that line nice and straight. And then let's look at this patient here. So let's look at the patient we've got in front of us here. What do you see postural-wise from the anterior aspect that's off? Okay, ears are forward, okay? Let's look at the anterior side first. So anterior aspect, front aspect. And we'll go to the right on the lateral aspect. So let's look at the one on the left side here first. Torso shifted to the left. Is that to the left or the right? To the right, good, okay. So she's slightly shifted to the right, right? And you see, does not pass through the nose, definitely doesn't go through the sternum. Does it even out just about at the belly button? You might have scoliosis, you're right. It evens out just about at the belly button, but even down to the pubis symphysis, if you look, it's still not at the right level at the pubis symphysis. So pass fairly evenly between the knees. Yeah, kind of, right? And when it gets down to the feet, overall, feet pretty even, right? So what that tells you about this patient is the patient's got some sort of a torsional component at the spine, and they're correcting it by the time it gets down to their pelvis, right? And that's going to happen a lot of times with patients is they may have a scoliotic curve, but they'll correct the scoliotic curve and get everything even by the time they get down to that pelvis level. Right? They could have a really wicked scoliotic curve, but they'll correct it based upon other places in their body. I'm not saying her curve is that bad, but she definitely has something going on here, right? What about the shoulders being even? What do you see about kind of looking on that horizontal scale? Let's go up to the top. Are the ears even? Straight line. So look in here. Let's look through the inferior aspect of that earlobe. Ears a little off. Yeah, they're kind of even, but they're a little off. Not bad, right? Her eyes are pretty even, so that's normal. I'd say her smile's kind of crooked, but hey, who am I to judge? But when we get down here to the shoulder, look at the space there versus the space there. Yeah, right? That left side is significantly higher in this pace, right? Her hairline. So her shoulders are definitely kind of shifted. And if you look, that then throws off that midline, right? We get down here, probably right about there's her midline of her belly, right? Overall, that's okay. But I bet if we get down here, I'm guessing right about there and there are her ASISs. So her pelvis is probably off. And you can even see that if you go down to here and, oops, that's still the straight line. I don't want the straight line. Erase that one. I want the curvy line. Give me my curvy line. If you go down here and look at her knees, what do you see different about the knees? Can you tell a difference in the overall tone of the knees? Which one's locked and which one's a little bit not as locked? Just by looking at it? It's hard to tell. Yeah, I agree. You have to kind of have been doing it for a little while. But if you look on, let me get my drawback. If you look on this right side up here, we've got a little bit more soft tissue on that right side, whereas on the left side, things are a lot tighter. Yeah, the right's locked, exactly. So we got a little bit more soft tissue kind of going along. The left side's a little bit kind of looser, right? So all these we're going to document when we get in there. How about overall foot position? Are her feet pretty evenly facing forward? Not really toed out, not really toed in? That look pretty good? And we get down to the feet look pretty good, right? Not much of a foot person, but left big toe is pointed up, you're right. So we might have something going on in the arch, which we might have to see from the interior side as well. But you're right, that big toe is kind of like joined up a little bit there, right? You can see a little space under the toe. Just imagine being this model for this posture assessment, knowing that multiple people across the world are going to use her as an example. I'm hoping they told her to stand off. Now let's go over here to the lateral aspect. And I believe, as Kelly already said, the ear is definitely further forward than it needs to be, right? So that ear is off. Does it go through the acromion pretty well? Does it look like it goes through the acromion? Yeah, it looks like it goes through the acromion. I'm guessing if we look at it, she probably has a little bit of sway back here, meaning she's got a little bit more lumbar lordosis. I'd have to get the arms out of the way to see that more. She probably has increased lumbar lordosis just looking at her. And the main reason I say it is if I look at her from the front side of the aspect, her abs are tightened down when she's standing, which means she's overcompensating with those abs. Passes just posterior, because about here is going to be her greater, oh, that wasn't a very good drawing. About here is going to be her greater trochanter, so she's a little off at the greater trochanter, and I'm guessing that's probably caused by that sway back. When we get down to the legs, is that a little bit further? That's behind the patella, but that's a little bit ways back from that patella. When we get down to the lateral malleolus, again, we're back to normal. And this is normal on a human body, right? We may have a pronounced curve here. We're going to correct it, overcorrect it, correct it until we get to here. That's still going to throw off everything below it. So we need to be able to assess it. Once we kind of look at this patient and we've kind of gone over what their body looks like, the next thing we're going to do is we're going to put them back into the same pose. So I'd go over these pictures with my patient. I'd say, look, let's look at your overall posture here and kind of break it down and destroy their self-esteem. Once we have them sufficiently beat down and crying, the next thing we're going to do is help them. So then we put them back over and have them stand back at the postural grid. And we're going to go in and preferably do manual corrections, where we're actually going to do some tactile cueing and move them around. But again, you have to make sure that that's appropriate. And make sure that you don't say something like, I'm going to touch you now. That doesn't sound appropriate. Right? Let me touch your pelvis, please. No. Yeah, we did point out a lot for this model, right? And you know what and it's funny, Eric, is when looking at this, how many problems do you think this patient actually has? It's going to surprise you. The patient probably only has one main problem. No, she probably does. I mean, this patient, this is a real patient. They probably have one main problem or two, and it's probably a scoliotic curve, right? Because you're going to have a primary scoliotic curve and a secondary scoliotic curve, which is going to correct it. But because of that one scoliotic curve, it throws everything off. So because you have that one, I have somebody, I think they're cleaning my windows outside, and I just heard squeaking, so it was really annoying. So because you have that scoliotic curve, it throws kind of everything off. So does it mean she has a lot of problems? Probably not. What it does mean is that she's got one major problem that we need to focus on. So the first thing we're going to go to is, okay, I'm typically going to start either feet or head. It depends upon what I feel like that day. It doesn't really matter which way you start. But I'm going to go along. First thing I'm going to correct is maybe her head. I'm going to make sure her head's straight on. And then I'm going to tactilely correct her spine and bring her shoulders over into alignment. Now, once I bring her shoulders over in alignment, the head may come off alignment. So now I've got to go back up and correct the head alignment. And then I'm going to come down and correct the main area through the thoracic bodies, make sure everything's nice and neat. I may have to shift laterally the pelvis or even out the pelvis. I'm looking at this and just looking at her. Her pelvis definitely looks like it's kind of doing that, doesn't it? Yeah. So that means we've got to bring her pelvis back into alignment or it's more of a straight line. You can tell by the waistband, exactly. Now, the other thing you have to make sure of there is that it's not somebody that's got the waistband pulled down on one side or pulled down on the other. And you may have to have them pull their waistband down below their ASIS. And that can get a little awkward too. I've had it awkward where, well, then, well, poof, let's just go there. So you got to make sure that you can see everything. But you need a clear view of this patient. Ideally, underwear and bra or underwear is the ideal thing for this. It may be the most awkward, but again, your patient is not coming to you to pose for standing in the nude. No, your patient is coming to you because they've got a postural problem, and you need to be professional enough that if you have to take, assessments in very little clothing, that you can be professional about it, right? Other things that can throw these kind of postural assessments off, right? What if instead of having this nice tight core that, I'm kind of jealous of, instead of her having that, she's got Dunlap's disease, where the belly Dunlaps over the belt. Right? Now we've got more palpation going on because we may not be able to see everything as evenly, right? If they've got some sort of a pannus, which is what that's called when you have that stomach fold that folds over, you may not be able to directly be able to see those ASISs. You've got to get hands-on again. And when you get hands-on, you need to tell your patient, don't ever just grab a hold of your patient. Make sure you're explaining to them, okay, so I'm going to come down here. I'm going to get on those bones of your hips. Okay, let's take a look. Okay, we need to even that out. Okay, I'm going to get on the outsides of your hips now. Find those big bones on the outsides of your hips. The more descriptive you are, the safer it is for you. Now, guys, I'm going to stress this. Now, it can be with girls too, but I'm going to stress this with guys. If you are doing a postural assessment of a female, I would highly recommend having either another female within viewing range or even having them in as an assistant for your postural assessment. It doesn't always happen, but you don't want something you're doing to be misconstrued. Ladies, you have a different problem. Guys often, when they're working with females, have a problem with what they're doing being misconstrued. Guys that are patients have a tendency to misconstrue things differently, whereas a female may misconstrue things that it's offensive and kind of not what they want to happen. A lot of times, a guy will misconstrue things in thinking that, oh, well, hey now, right? So you've got to be able to be paying attention to these kind of things when you're working with patients because you don't want them to misconstrue what you're doing. Trust me. The last thing you want is your patient misconstruing what you're doing. I'm just telling you from experience, you don't want it to happen. Does that make sense on the overall standpoint for posture? I mean, overall, not in depth, but overall, does that make sense on how the posture is kind of assessed?
Mr. McKeever?
Hold on again. Let me turn you up so I can hear you. All right, I can hear you now.
All right, so I don't have a question on that, but as far as our walkthrough comp tomorrow on this, how is that going to go with this?
I have a picture that we're going to go through.
Okay, cool.
Yeah, we're going to kind of all do an assessment of another picture of basically another student. I'm going to remove the face, and we're going to do a full-on assessment on how it works. Does that make sense? So we're going to look at that student and do an assessment of their posture. And what we want to do is we not only want to be able to tell what's off, but maybe have some ideas how to correct it as well. Does that make sense? Okay, good. The client once told him he needed to calm down or I'd get a mail to help him instead. Yeah, that's happened. I am often the person that gets brought in when that male can't calm down. Just saying, you know, usually works out pretty well. And, you know, especially if you, I can't remember which, I think Tyler's an LMT. I don't know if I forget if anyone else is actually an LMT in our group here. But you'll find, especially with doing massage, that guys have a tendency to, is just Tyler? Okay. Yeah. Guys have a tendency to misconstrue a massage really easily. And I'm not saying women can't either. And I'm sure Tyler can speak to that. I've had some women that have misconstrued massage, not as in thinking I'm assaulting them, but way misconstrued what I meant by a massage. And that gets awkward. And I will do the same thing as I'll, you know, I'm sorry, I give you a warning, but after that, I'm bringing it next time they're getting booked with the female. I'm just not dealing with it. I just don't have time to deal with lawsuits. It's not happening. So you have to kind of pay attention to that when you're working with patients. Don't consciously change the way you act, unless the way you act is causing the problem, right? But be conscious of it. Be constantly kind of paying attention and going, okay, could what I'm doing being misconstrued, right? When we were doing the what do you call it? Oh my gosh, positioning and draping. Anytime that you reach under clothing or reach under a covering, make sure you are very clear about what you're doing, right? Almost to the point of being redundant. Okay, I am going to move this blanket out of the way so that I can get access to your foot. And the patient's like, why are you telling me this? Just treat me. There's a reason why I'm telling you this, right? Because you want to make sure that they are aware what you're doing is professional, not personal. And it's going to happen. You know, in my field, what I work in quite frequently, working with pediatrics, I face it with single moms quite frequently, and they get attachment issues. It's sad, but you're the only one paying attention to their child, and attachment issues develop quite frequently. Ladies, I do not envy what you have to deal with guys. I just don't. But guys, you'll find out the absolute worst will be little old ladies. Yeah, we always think that little old guys are the most perverted. They got nothing on little old ladies. Just wait. They are, yeah, they're fun sometimes. They're the best, exactly. Yeah, the best is the term I wouldn't exactly use, but sure, we'll go with that. They can be fun. They can be great little people to work with, and they really appreciate when you pay them attention, but sometimes appreciate a little too much. So like I said, we're going to go through tomorrow and we kind of do the walkthrough comp. And again, this is going to be really informal. And when we get back to campus, we're going to kind of re-go over this where probably I'll have you guys assess my posture. And as a class, you'll kind of look at my posture and figure out what's looking off, what's looking even, so that we can just refresh this before you guys go out in your first clinical affiliation. Because posture is something that's really easy for us to assess. Now I want to go back to this girl that we were talking about here with this kind of scoliotic curve. If I'm looking at her, she probably has a scoliotic curve going something like this, right? Let's talk briefly treatment-wise here. And we're going to talk really briefly because we're going to cover it a lot more when we get into the spine in thorax. We're going to divide these into two curves. We're going to call it curve 1 and curve 2, right? And, you know, all women have curves, but this one we're definitely looking at a spinal curve. When we look at curve 1, what side of the spine is going, and remember, so let's look here. So she's looking at us. So this is right This is left. When you're looking at curve 1, what part of the spine is going to be tight? The right or the left side? Okay, so I got left. Do I have any other votes? Are we going to go with Kelly? She our spokesperson? And she would be correct, because the cantilevered side is going to be that tight side. It's been shortened, right? So that means on the right side, it's lengthened. So when we get into treatment of this patient, what we are going to want to do for this patient, right, is on this left side, we're going to want to stretch it. On this right side over here, we're going to want to strengthen it. That will help overcome this curve. So we want to stretch the tight side, strengthen the stretch weak side. And this is going to come into play pretty much from now until the end of eternity as physical therapist assistants. When you have a tight muscle, almost universally, you're going to have an opposite muscle or an antagonist that is stretch weak. So I'm going to use this as a quick example. Let's say my biceps are contracted. Look at those guns. Look at that, right? All right, so if my biceps are contracted and I'm stuck here, that means my biceps are tight. What muscles are probably going to be stretch weak? Triceps. Good. So what we're going to want to do is we're going to want to stretch my biceps back out, and then we're going to want to strengthen my triceps. By doing a combination of that, you'll get me out of that contracted position. So same idea here, and there are a couple of things we can do for this with this specific patient. I'm going to erase my red marks here, right? We can do something as simple as having her lay on a foam roller right at that curve. By laying on a foam roller at that curve, that's going to force this curve to stretch out. And it'll stretch that side, right? But then we can also have her do side bends, right, over this way. And by doing those side bends, she's going to get a little stretch going on, but she's going to strengthen that side that is stretch weak. Does that make sense? So when we're looking at a patient, we want to figure out what's tight, and then contralaterally what's stretch, or not contralaterally, but opposite side antagonistically, what's stretch weak. So let's come down here to curve number 2. All right, so now we're down at curve number 2 down here. What side is tight on curve number 2? Good, right? So this is my tight side. If that's my tight side, then what's the other side going to be? Typically tight, and this side's going to be stretch weak, right? Or it could just be stretched. It may not necessarily be weak, it just may be overstretched. But a lot of times when you've been under that stretch for a period of time, those muscles lose the ability to return to their normal shape, so they truly become stretch weak. This is a really important concept. If you can get this concept, this makes physical therapy so easy. Because then you can use what we're going to talk about later in Therex, when we talk about reciprocal inhibition, to help with stretching and strengthening. Because if you understand, well, if this side's tight, the other side's probably stretched, well, I can use those in the opposite of each other to treat the patient. Clear these real quick. So let's come down here. We're going to use her abs and her back, for example. So she's got a curve going like this, right? She's got a hyperlordotic curve, meaning her lordosis of her lumbar spine is great. When you look at that lordotic curve, what muscles are overstretched? If you look at that curve, What muscles? Yeah, right? Her abs, rectus abdominis primarily, right? So her abs are covering that whole distance. Right now, it's not 100% to scale. Please bear with me. I'm not a very good drawer. Right? But her abs are going to be stretch weak. That means what muscles are going to be tight? Yeah, the erector spinae group, right? So these muscles here. So now I want to take that a step further. I actually want to erase this purple a little bit and draw it a little bit better. So here's her abs. Her abs are stretched out. Now, do you remember when I drew that diamond for you guys? So here we have rectus abdominis. Here we have erector spinae. Here we have hamstrings and glutes. And here we have iliopsoas and quads. Right? So if her rectus abdominis is stretch weak, what other muscle is going to be stretch weak with it? Do you remember this from last week? Yes, the hamstrings, glutes, right? So it's going to be the one diagonal from it, right? So that means if the erector spinae is tight, the iliopsoas and the quads are going to be tight. And how you can know that is her pelvis looks like this. Or actually, her pelvis looks the other way. I drew it wrong. Erase that, right? Her pelvis, let me draw where's my straight line? Her pelvis looks like this. So these are short, right? These are short. These are long. So working with this patient, we're going to stretch the erector spinae group. We're going to stretch the quads and iliopsoas. We're going to strengthen her abs, and we're going to strengthen her hamstrings. Now, we haven't even gotten into any exercise yet, right? But let's just use some logical thought processes here. Let's say we wanted to stretch the low back. What could we have her do to stretch her low back? Touch her toes. Good. Easy stretch for the low back. Great. Now, how about if we wanted to stretch the quads and the iliopsoas? There are a couple different stretches that are probably out there. Anyone? Standing quad stretch. There we go. Lunges. Excellent example. We can do a lunge, and that makes things really simple, right? We don't have to teach her anything. We can have her do a lunge, and we'll get a quad stretch out of it, right? We can have her do the one where you grab the foot and pull the foot up behind the back and pull that quad back. There's the kneeling quad stretch. There's all kinds of quad stretches out there. And we're going to show you different ways. I'm going to show you different ways that you can stretch where you'll focus on iliopsoas primarily versus rectus femoris primarily, right? It's all in the way we put the knee. All right. So we've got those. Those are getting stretched out. How would we strengthen her abs? What could we have her do? Sit-ups. Okay, good. Could you do planks? Okay, yep. Could you do nice isometric hold. Abdominal bracing, the simplest one we can have her do. Good, right? Have her do crunches. I usually prefer crunches over sit-ups because I have a habit of watching patients when they do full sit-ups, yanking their head, right? Pelvic tilts. Pelvic tilts and bridge are great. And you know what the best part about pelvic tilts are is we're going to get a stretch and a strengthening at the same time with the pelvic tilt. So you get a 2-for-1 out of it, right? So there's all kinds of ways we can do this. Now, how about strengthening the hamstrings? What could we have her do to strengthen her hamstrings? Curls. Okay, good. There's the simplest one we can get at the gym, right? Leg curls. One of the other things I really love to do with patients, heel slides could work. Yep. One of the things I really love to do with patients is put them on a low stool in the clinic and make them pull themselves around by their heels. Hamstring isometrics, right? Ham sets. Good. Do you see how that, though, these classes come together, though, in looking at these different, when we're looking at the posture, what we're really looking at is, what are we going to treat them with? I hate doing that workout in college. Yeah, it's miserable. Yeah, usually my patients, when I'm doing the walks on the stool, they're like, well, how many reps do I have to do? I'm like, oh no, you're doing it for 5 minutes. Get going. Go around the clinic for 5 minutes. It really kills. And if you don't think it will, try that at some point in your house. Get a nice chair that's on wheels and pull yourself around by your hamstrings and see how sore they get really quick. Yep, there's all kinds of things we do, but do you see how that kind of plays into effect? And all that came out of her posture assessment, right? And the PT may only give us, so we'll go ahead and do this posture assessment. We hand them our posture assessment. Now, when we hand a PT a posture assessment, we're not saying that her posture is thrown off because the glutes are tight, the hams are tight. We're not saying that. All we're saying is, here's what we got. Here's what we found for the PT. The PT then is going to interpret it and come over here and kind of draw this out for us in the plan of care, saying, oh, well, the patient's hamstrings and rectus are stretch weak. The erector spinae and quads are tight. So we're going to set goals to improve those. And then we have to oftentimes translate that into exercises. What you're going to find really quick is we're going to go over manual muscle testing in this class. When you're absolutely at a loss for a manual muscle or for an exercise, you can turn a manual muscle test into an exercise. And then you can also reverse that manual muscle test and turn it into a stretch. So when you're absolutely your brain is just, poof, I can't think of what to work on for this muscle. Because it'll happen, and it's usually stupid things. Like you'll be sitting in the clinic and be like, it won't be something like, well, I don't know quite how to work the TMJ. No, it's going to be something like, what exercise could I do for the biceps? And somebody's going to throw a book at you from across the room that's like 450 bicep exercises. But for whatever reason, at that given moment, that brain fog just kicks in and I don't know what exercise to do with biceps. Well, do the manual muscle test and turn it into an exercise. It's amazing how silly that gets in the real clinic, though, is that your brain just gets this fog and you're like, I don't know what I'm supposed to be doing. But does that make sense, though, looking at that postural assessment, how just doing a simple postural assessment can help us develop exercises for this patient, right? And what I'd send this patient home with, right? Because I need to send them home with some exercises. I'm going to send them home with pelvic tilts, like who was it that I mentioned? Tyler. Pelvic tilts are going to be a twofer for me, right? If I send them home with some pelvic tilts, I'm going to get a little bit of a stretch and a little bit of strengthen out of them. And then I'm going to send them home with a lot of setting exercises. So those isometric exercises that I can eventually build up to something like a plank or a bridge or something to that effect to get them to do more activity, right? But again, I'm going to send them home with 3. That's it. So in this case, with this patient, I'm probably going to send her home with some tilts where I'm doing some anterior pelvic tilts, right? I'm going to send her home with some quad set or some glute sets and some ham sets and maybe a little bit, 1 quad stretch. I sent her home with 3 activities. I want you to do those a couple of times. Does that overall make sense, though? This job seems really complicated, but it's not as complicated as you would think. There's a lot that goes into it, and there are a lot of exercises. I may have said glute sets, quad sets, and some of you are like, what the hell are you talking about, Mr. McKeever? Don't worry. We're going to go over them. But some of you are like, got it. Yeah, no problem. I'm good. That's okay. That's what we're here for. But it just shows you how simple something like this can be just by looking at this little exercise here, right? Looking at the muscles across from each other. It's really amazing just how simple our job is when you break it down to that. Now, when we get into like the brain in that, not as simple. But when it comes to straight thorax, it's pretty simple. It's a stretch or a strengthen, right? Or we're building up some endurance for some cardio training. But it's pretty rare that it's not something that you can solve with something really easy, right? Could I have this patient do sit to stands as an exercise? Would that help some of her problems? Did I lose anyone yet? Yeah, I could, right? I could even take it a step further. It would help a little bit of the hamstrings, absolutely, right? Especially in that eccentric loading when she sits back down, right? I could have her do sit to stands while she touches her toes, right? And I may have her bend her knees so that I eliminate the hamstrings from the stretch because the hamstrings are already stretched out. So there are ways that we can work this, that we can give her something that's really simple to do, right? Well, I can't do these because I work for 8 hours a day. Can you stand up? Well, yeah, I can stand up. Great. Can you put your knee straight at your desk and kind of push your foot into the floor? Great. You can do a handstand. So there are ways we can give them even something simple as that to get them to exercise where they'll say, I don't have time to do it, and it's proven we're not. So what I need now, I'm going to go ahead and stop the sharing here. Stop the recording. What I need now, since I missed yesterday,